Today, we're incredibly lucky to have Dr. Richard Boles to join us to go over. He's basically the mitochondria master, and we're just going to give a little bit of a background on you, and then I'm very excited to chat with you. So, Dr. Richard Boles is a medical geneticist and a pediatrician who specializes in mitochondrial medicine, functional disease, and autism spectrum disorders. His expertise stems from decades of both clinical work and research at a major academic center, as well as from his most recent experience in cutting-edge biotechnology and genomics. He uses an innovative and integrative approach in both diagnosis and treatment to best serve his patients. He treats children and young adults with a variety of conditions, but his main focuses are mitochondrial disease and dysfunction, ASD, complicated migraines, including cyclic vomiting syndrome, and other chronic pain disorders, and chronic fatigue syndrome, just to name a few. But thank you so much for joining us today.
Well, thank you for inviting me.
Absolutely. So I know you have some slides. We can definitely field some questions from the audience as they pop up. But I think I would actually love to know how, in your medical and in your scientific journey, how did you kind of fall into ASD? How did you take that on?
I was working with patients with cyclic vomiting syndrome, which is a complicated type of migraine. They have vomiting and nausea, and they're very lethargic, and it can last for days, even up to weeks at a time. You can have episodes every couple of weeks or every month or every few months. And I was using that to look at migraine and chronic fatigue and irritable bowel and all of those chronic functional disorders, because the ones with cyclic vomiting have that. And then it's more often in girls than in boys. And I was realizing that all of the girls that I had brothers with autism. And if they didn't have autism, they had ADHD. And many of them had autism or ADHD themselves, maybe 25%. But there was a huge amount of autism in the population. And I knew that, autism is really common and it's getting more common, but it was kind of ridiculous. It was like almost every family had someone with autism in it. So I started to get involved in that. I realized that the genetics of autism is very much the genetics of the diseases that I was looking at. And so I started adding autism to that. And then, of course, autism is this huge, giant area that once you step in, you kind of jump into the pool and drown if you don't swim. So that's how I got there.
Yeah, I've actually never heard that. So that's amazing that you obviously saw the connection there. And I'm assuming you also have posted or probably published on the fact, because that's a really interesting correlation between the two, between cyclical vomiting and then having a brother, most likely, on the spectrum. It's very interesting. Okay, so then, how long have you been doing this for? Like, how long have you been in the ASD world, which is a absolute rabbit hole, as you said? And how long have you been doing this, and how long have you been treating ASD children?
Well, kids have come to me as a geneticist with autism for 30 years now, and I've been treating them. Most of them have mitochondrial dysfunction, and I've been treating them with mitochondrial cocktails for 30 years. But how long have I been really focused on autism? Probably about 8 to 10 years.
Wow. Well, that's wonderful. Okay, so why don't you walk us through, obviously you're a geneticist, and I remember I was actually have seen you speak obviously in the past, and you had actually mentioned something that I found really astounding that I've never heard anyone actually say, which was that you were able to, with your clients, because you do the whole genome sequencing and you're able, and that's your bread, that's what and you were able to basically see what the cause of your client's autism was based off of the whole the whole genome sequencing. Can you obviously that's a huge situation, but can you down for us and how you were able to, with your clients, differentiate their autism?
I will try my best to answer the question.
Okay.
Just 10 years ago, autism was, we call idiopathic. The doctor's an idiot and the patient's pathetic. Means that we have no idea idiopathic what it was. There were people not that long ago who was debating whether autism even really exists. That when I started in this, that really was the case. A lot of people said that, there is no such thing as that. They're just people with developmental delay, mental retardation, they used to say. But now with whole genome sequencing, we know what autism is. Most of my patients have an exact diagnosis, and I can tell exactly on the molecular level why it is that they have it. Exactly everything that's going on in the brain, that's something that we don't understand yet, but the underlying cause in most patients is known. In some patients, there's a single mutation. That's probably about 50% of patients. It's a single mutation that causes autism, and it's not present in the parents. It's a de novo, new mutation. And then about 50% of the time, it's genetic risk factors that usually were inherited from both parents. And those are, it's about 50-50 or so in my practice. And I'd say that about 80% of the time I can pigeonhole it in one of those two categories and then say, well, this is why your child has autism. Not every time, but most of the time now.
That's amazing. So what is your approach then versus the de novo, and then versus the ones where there's a genetic susceptibility and there's a mutation that they inherited from their parents?
Well, there's really two different conditions going on here, but there's a fuzzy line between it, and some people definitely fall in the middle. So if you're fall in the middle and you say, well, my kid's really kind of in both, that sometimes happens. On one side, there are children that have developmental problems from very early on. You know it in the first few months. Mother often, suspects something pretty early on that something's not right. There's significant developmental delay. There are other problems. There may be epilepsy. There may be speech apraxia. There may be other issues, ADHD or something else. And usually the family history is rather negative. And those cases, by and large, are de novo. I mean, there are exceptions, but by and large, it's a single abnormality that occurred genetically that's not in either parent. And we can identify that when we sequence all 3 billion nucleotides of the mother, the father, and the child, and use a computer to compare and see what's different in the child that didn't come from the parents. So that's one type. The other type are the people that often have normal intelligence or maybe a little bit below, but very oftentimes they have above average intelligence. They have special skills, like they're superpowers sort of things. They have some trouble in social situations. They may have some difficulty with language, but they're in the normal community, and for the most part, or almost, normal people. They have some issues, and they can be helped with certain things. And usually there's a family history that people in the family, either they have issues such as developmental, ADHD is really common, autism, epilepsy. But more often than not, the family history is people that are actually hyperfunctional, is people that are very highly autistic, they're very highly artistic, highly intelligent, really good at their career. And because a little bit of autism can really be helpful. It helps you to look inward and be able to study instead of going out and partying and basketball or something. Not that those things are bad, but people that can turn inward can do those things and can think more creatively. I mean, name a billionaire, and there's probably someone with autism or ADHD.
Yeah.
And so those are usually inherited, sequence variants inherited from the mother, sequence variants inherited from the father, and it's a different situation.
No, absolutely. That's amazing. Okay. And so when you have, obviously your first thing, I would say maybe your first thing that when you get a new ASD patient is that like your first out of the gate, like, let's just run whole genome sequencing. Let's see exactly like under the hood, let's see what's going on. And then obviously you take your targeted approach from there, because obviously there's such a spectrum, everyone's so different. But is there anything that you really see that is very the same, even between the two groups? And like you said, there's always that gray area in the middle.
Yeah, and some people have both. There are people that have a de novo and they have inherited variants as well. So they overlap. I get a really good phenotype. My initial intake is usually around 3 hours. I try to hold it down a little bit, but it often takes 3 hours because I know that I'm going to be looking at 40,000 variants. That's a real number. And I need to know, which of these variants are likely to be related to the patient and not just normal things, and which ones are likely causing disease, and which ones can I treat. And I really have to understand the patient and the family history in extreme detail and understand what are the concerns about the parents, of the parents regarding the child, and not just a laundry list of issues, but really what are the major problems. So the first thing is to really understand the patient. That's done by asking a million questions and going through the chart and looking at the labs that have been done before. If an MRI or an EEG or genetic sequencing or metabolic things, if a muscle biopsy or other biopsy was done. I mean, to take a look at those results to get an idea of the patient. And then, so that's the phenotype. That's, what the clinical manifestations are. And then I look at the genotype, or the entire genetic sequence of the individual. And of course, I've already looked at the parentals and removed that. And then I look for the various sequences. And then I get on a Zoom call with the family, and we say, okay, these are the clinical manifestations, and these are the findings, and let's connect the dots. And that's, I'll ask some more questions. I can take a look at the patient. Are the fifth fingers bent? Is there a family history of anesthesia problems? Does the child have some speech abnormalities? I can take a look at the patient. We can talk about the family. We can say, okay, what did the MRI show? And try to fit it together. So it's that stage of really going through and knowing the patient, then knowing the genetics, and then connecting the genetics to the patient. That's where really the power is.
Absolutely. And I know you had mentioned in another talk you had that you had said basically, there's hundreds of things that obviously that you can treat, and of course there's some things that you can't. What does that look like to you? So once you receive that information and you have that child, and you're looking at the child, looking at the full, like, under the hood, what is your approach at that point? I mean, I know you had mentioned before, it's really everyone has a mitochondrial disorder at this point. But is that kind of one of those, like, staple needing to get that kind of under control before you can go and hit the other things, or what is your approach?
There's really two major questions in there. Let me handle them one at a time. If I can try to remember. First of all, let me show you some DNA.
Please.
So this is a presentation that I gave, about 9 months ago or so as part of the Brain Foundation Synchronicity. I just want to show a couple of ones here. Let me find the right slide. So this is an Excel file that was done by Chris Phobes in Gene Savvy, kind of runs my IT to do this. He takes, I believe this was a GeneDx whole exome sequence, but we can use a few other labs as well. Not every lab has good enough DNA results to be able to do this, and then turns the whole thing to an Excel file. And the Excel file has, about between 20,000 and 40,000 rows on it. I'm not kidding, because that's how many sequence variants that we're looking at. And this is just to show you that the variants I can order, I can say, well, which ones go on top are the ones, first of all, I'm looking at it to have a particular gene list. These are the genes that have been associated with autism and related disorders. And after I look at this list, I look at the entire list of 23,000 genes. But these right now are only the autism genes. And the ones on top are the variants that have not been seen before, that are very, very rare in humans. And then among the ones that are on top with 0 in column T, in column P, it's looking at other species. So the ones at the very top are ones in which every single species of the hundreds of species that are on the databases, that every species has exactly the same amino acid in that location. Because if it's an important part of the protein, it's probably going to be the same in all the different species. And if it's not an important part of the protein, different species generally have a different amino acid code at that location. And of course, if it's something that causes disease, it's going to be very rare in humans. So the ones at the top are the ones that are most likely. Now, a lot of times I find the cause of the disease way down on the list. Sometimes it's a few hundred down or something, and I have to look very carefully. Occasionally, it's far down, it's 1,000 on the list. But this one right here, I want you just to look at row number 3. Row number 1 is telling me what's in the column. So the row number 3 is a GABA receptor. And you see, I know it's going to be hard to read it, but it's sort of red all the way across. And in column I, it's telling me that a laboratory at some point said this exact sequence variant is pathogenic, meaning it causes disease. Everything just fit completely. The next thing I did is I looked at the two parents, and they didn't have that sequence variant at all. Of course, I looked at the rest of the sequence because there are a bunch of other stuff in the sequence there that, might be important. And there were other things in this patient, but that was immediate. When I put this together, I mean, literally within the first 10 seconds, I knew what this kid had, because this particular GABA receptor R2 really fits the patient very well, who had intellectual disability, autism, and epilepsy. And then I was able to tell the family what it was and how to treat that. So we did things that were based on GABA, particularly trying to increase GABA. There's my kittens. And here's here's another slide here. This is a patient who was 18 years old when I first dealt with him, and he's got, some mental health issues and some functional disease issues. And this shows that, the overlap between what I said, functional disease, GI pain, fatigue, vomiting, that sort of thing, and autism, developmental delay, neurodevelopmental. So he's got a little bit of both. And then, but he had a sequence variant in this gene that takes creatine across the blood-brain barrier. And this was actually the third sequence variant I discussed with the family. First one, they said, nah, I don't think that one fits. Second one, no, it doesn't seem to fit either. Third one, they really perked up and said, this one fits completely. Everything that's been discussed about creatine transport disorder fits. And this really goes into show that, I mean, laboratories do a lot of good work, and I was the director of a laboratory before, but they don't know the patient. They don't have the family in front of them. They don't have the patient in front of them to look at. And when you connect the genotype or the DNA sequence to the patient, that's where the real power is. And they said, okay, based upon this, we're going to make a tentative, this might be the issue. The family put him on creatine. The problem is getting creatine from the blood, from the brain into the blood. Creatine didn't work, so they used cyclocreatine, which is in a bunch of energy drinks. Cyclocreatine goes across into the brain, doesn't require the creatine transporter, and turns into creatine in the brain. And he got dramatically better. And those are the improvements that were noted by IT. But the OT was used as a blind. No one told the OT that any changes were made. And the OT said, what's going on with him? He's a completely different person. And I said, okay, please tell us what's different. And these are the things that were identified as being significantly different.
That's wonderful. And is that just kind of like run of the mill for you kind of results? It seems like, because if obviously, I mean, that just seems, it's an interesting thing that you, of course, those of us who have been in the ASD community for a while, of course, we've heard of whole genome sequencing, excuse me. But it doesn't seem that most doctors, that's not the first thing. I know it's expensive, but doesn't seem like it's the first thing that people are telling you to do. So it's an interesting thing that's your approach, and you're able to see, it might be because people, maybe they can't, like you had said before, you need to have someone who's able to, you can run the test, but then you need to be able to read it. So that's where you come in, and that's amazing.
Well, I mean, both of those cases that I just showed you were missed by the laboratory, because the laboratory doesn't really know the patient. It's not, to say anything about the laboratory. Is that if you just go with what's in the laboratory, you can make a diagnosis. Most people are saying 25% or less. Academic institutions, they're taking a look at the patient as well. They're saying up to 50%. I think I'm getting higher than that, because I'm looking at things that I think that are related to the disease but aren't caused. But like I said, the risk factors that are contributing. You might have heard about Dr. Temple Grandin.
Yes.
She's a well-known author who has autism. This is her DNA sequence. I did her whole genome sequencing. Interesting about Dr. Grandin, I've spoken to her many times before, autism is a superpower for her. It allows her to be not just that she's now known for writing about autism, obviously that was, but before, when she was a professor of animal science, it allowed her to really get in with the animals and see what they were thinking, and to say, no, we need to change the way that we treat the animals, because they're very nervous about this, and this is how we change it. And she made a big difference in that long before anyone knew about her as having autism, because it gave her special abilities. And when you ask her, about autism, she says that's not a disease, it's a trait. There's good and there's bad, and yeah, there's some bad things in her life about it, but it's really given her more than it's taken away by far. But what really, really pisses her off is that she'll stand at lectures, and she'll stand for an hour, and then her feet will be like they're totally on fire, like they were put in the hottest water. and they will swell up and they will become painful. And this happens every once in a while. And she's had this since she was a little child, and no one can figure out what's going on. This is what she really would like help with. Well, she has 2 known mutations in the pyrin gene, MEFE, that cause familial Mediterranean fever, which is what the situation is. And both of these are very common. One of the sequence variant is seen in 1.3% of the population, the other in 1.4% of the population. But they are risk factors. They don't cause disease, they cause risk for disease. And this is a treatable disorder. She also has a whole bunch of teeth that never came in. And she, talks about that once in a while. Well, she has a known mutation in a gene that's involved in making teeth. And then there were several other sequence variants. You said, well, what about her autism? That's probably SHANK2. She has a variant in SHANK2. SHANK2 is the gene that holds the synapse together. You think that, the 2 nerves don't touch each other, that there's that synapse that the neurotransmitters go across. Well, there are proteins scaffolding that hold the 2 neurons together, that hold the synapse together. And that scaffolding involves SHANK2. And she has a mutation in SHANK2. People with SHANK2, it's one of the more frequent causes of autism. I have a lot of patients with SHANK2 autism. So this gives you, sometimes there's an exact mutation, and other times it's more complex than this. But you have to really do a deep dive in the genetics, and you have to really know the patient, and then go back to the patient and really work it out with them.
I've definitely heard about SHANK2 and people having an issue with there. So let's use Dr. Temple Grandin for the SHANK2. What is that for those? Maybe there are some people in the audience who have a child or an adult with a SHANK2 mutation. What would be your approach for that?
Well, technically, if you look it up, there's no treatment for SHANK2. However, there's a lot of us that have been looking at this as what can we do about SHANK2, and to try to think out of the box. Mm-hmm. And one of the things that people that are proactive, some of the well-known autism doctors, realize is that in autism, a lot of times the excitatory to the inhibitory neurotransmission ratio is off. So they either have too much excitatory neurotransmission or not enough inhibitory neurotransmission. In other words, their synapses are going off too much and the brain's doing too much. What you see in these people is you can see autism, you can see hyperactivity, attention deficits, they can be impulsive, anxious people, they may or may not have migraine, they can have epilepsy, most of them don't. They really have hyper-excitable neurological statuses. And you would probably say, no, that explains my boy, or sometimes your girl. Maybe half the kids or so with autism have this sort of hyper-excitable situation. And some of the treatments that that people are using are to slow down the positive neurotransmission, the GABAergics. The glutamate system. The glutamate system is the number 1 excitatory neurotransmission. So you want to slow that down, and there's certain things to do for that. And then the other thing that you'd want to do is to speed up the GABA system. That's the inhibitory system. So you want to speed up the slow down, you want to slow down the speed up. And if I find a SHANK2, we double dip on that sort of thing. We immediately jump on that because the problem is in the synapses in that individual, or at least part of the problem. So we talk about things that affect GABA, particularly things like gabapentin if there's pain, magnesium, zinc. Sometimes we'll use other drugs that work on GABA. And then we work on the glutamate system, Namenda, which is memantine sometimes. Sometimes we'll use something like, there's several other drugs that can work on that system, everything from dextromethorphan to amantadine. I don't want to practice medicine here, but there are some things that your doctor could say, amantadine is something I might have used anyway. I was kind of thinking of it. That makes sense in this situation. And then there's magnesium and zinc as well. I use a lot of magnesium and zinc because they increase GABA and they decrease glutamate.
Perfect. Let's just maybe grab a couple of questions here from the audience so far. Someone asked how they get an appointment with you. I think that Enrique, he's put everything up. So we'll also have Dr. Boles' information linked everywhere, so you guys can be able to find him. And
that's Neurabilities. Yeah, contact Neurabilities. Look at the neurogenomics page, and it'll give you the contact information.
Perfect. And we'll also add the link on there so people can click and directly go. Okay. So someone was asking regarding like phosphatidylcholine. Is this one of the things that you use in your practice as well for as a mito supplement, or is it really, you kind of need like a combination of things to like layer?
So, it's a really good question. Let me go back to a second and then make sure that I get to that, because you asked a question. I said there were really two parts, and I kind of went on the first part forever. You did talk about mitochondrial dysfunction. Almost everybody with autism has mitochondrial dysfunction. In my experience, it's probably 90%. Studies have shown 70, 80% or so, but I think that's even higher. We're not talking about all these people have mitochondrial disorders. We're talking about these people have a mitochondrial dysfunction that's part of the disease. In a situation where you don't have enough creatine, creatine's used as a battery for nerve cells. So that makes sense you'd have an energy metabolism disorder. It's not as obvious in some of the other conditions, but it seems like regardless of where the genetics is, if they have autism, they have a degree of mitochondrial dysfunction. So one of the things that we do is we try to improve mitochondrial dysfunction, and that's done with cocktails of vitamins and minerals. Coenzyme Q10, particularly ubiquinol, the OL at the end, is very important. Carnitine, B vitamins, especially riboflavin, vitamin C, vitamin D, vitamin E, vitamin A and K, selenium, magnesium, zinc. There's a large number of, and then there's other antioxidants like alpha lipoic acid and N-acetylcysteine. And those are really, A, they improve mitochondrial function, and B, they remove some of the free radicals and acylcarnitines and other sort of trash or the pollution of poor mitochondrial function. So they help mitochondria work, and they sort of detoxify the mitochondria at the same time. So I use a lot of those. For many, many years, for decades, I was telling people to buy all of these different things. So then I got together with some partners and we made NeuroNeeds, and that is on the little thing that goes across on the banner, neuroneeds.com. And we made some products to help to put all of those together. So everything I mentioned, plus a bunch of additional products, except for NAC, are in Spectrum Needs, which is a powder, and Energy Needs, which is a capsule form. And then I have a Q Needs on top of that to give the CoQ, because the powders and the oils don't really mix together, and CoQ works much, much better in an oil form. So those things I highly recommend for those with mitochondrial dysfunction. What I usually do is I test the mitochondrial function at the same time as I test the genetics. So I order a mitoswab, which is from a company I don't have a conflict of interest with. And they do saliva, just like the DNA is done with saliva these days. It's sent to a laboratory, and they measure how well the mitochondria is working. So first of all, that tells me if there's mitochondrial dysfunction. There usually is. How the degree of mitochondrial dysfunction, and what part of the mitochondria it's not seemed to be working well. And that helps me, A, in that while the DNA is cooking, it can take 6 months from the time that we order the test to insurance gets around to, to doing it. It gets sequenced, it gets interpreted, we have an appointment. During that time, you have something to be able to treat your child with a mitochondrial cocktail. We get the mitoswab quicker, but I go ahead and test it because, they're vitamins. It's extremely unlikely to hurt. And if they do, you just stop it and it goes away immediately. And they often help. More often than not, they can make a difference, sometimes a great difference. So again, we'll get the mitoswab and figure out what it is. And then later, when we have the mitoswab data and the DNA data, then I can decide, okay, where to go from there. If it looks like a channelopathy, I usually use drugs or potassium on the channelopathies, depending on which channel is abnormal. If it's a primary mitochondrial disorder, then we'll go ahead and say, okay, we need more mitochondrial supplements on this case. If it's a neurotransmitter, there's various drugs for that. It really depends on where the problem is and if we can address it. And then there are some mutations in some genes that we really can't do anything about. And then you're kind of back to where you were before. And then we start talking about synapses and GABA and glutamine and everything. And now I told you to put a bookmark on that question because I'm sorry, I don't remember what it was.
Oh, let me go back to that really quickly. Oh, it was regarding phosphatidylcholine, and if that was something that you thought was helpful. That's okay.
Well, ADHD, I look at it as autism light. Most patients with autism have ADHD. A lot of patients with ADHD have a little bit of autism. They are different parts of the brain. You can have one or the other or both or neither, but they often overlap a lot. And I know that serine and phosphatidylcholine have been used in a lot of patients with ADHD. I mean, there's a lot of people out there that say that it helps. I have a son with ADHD. He's on my own products, plus and fish oil as well, omega-3s or krill oil. When you're talking krill oil, then you're talking about the phosphatidylcholine part of it. When you're talking fish oil, then you don't have the phosphatidylcholine part of it, but you get much higher numbers. So it's sort of a catch-22 is, do you use fish or krill? I tend to like to use both. But outside of ADHD, there's not a lot of, in fact, there's not that much data at all in that area. Some people say that it helps, some people say that it doesn't. It's hard to say.
It's subjective, basically,
Yeah.
Makes sense. This is a question from Gabrielle, and she said, do you think this is an autoimmune/inflammatory component like PANS? I think that I'm not sure 100% what she was referring to. Maybe ASD is an autoimmune and inflammatory component like PANS.
Well, I mean, it's not infrequent that I find abnormalities in the inflammatory genes, in genes that are involved in inflammation. Sometimes they're in tandem with genes and other pathways. And there may be like a SHANK2. I mean, let me give you, like in Dr. Grandin's case, she has an MEFE mutation that's involved in autoinflammation. That's an autoinflammatory disorder. And she has a SHANK2. She has both. So I would say that it's frequent that I find abnormalities in the inflammatory and immune genes. And those tend to be the patients that are like the PAND or PANDAS type.
Okay. That's interesting. And here's a question from, I'm sorry if I mispronounce your name, Kanak. What about the role of the gut microbiome? Obviously, this year and last year has been a huge, uptake of information and, about FMTs and Dr. Adams studies and, the microbiome and the second brain. And what are your thoughts as well on that?
I mean, let me go a little bit backwards and kind of give a little bit of the 30,000 foot view. Every disorder in every patient has a genetic and an environmental component. There are people that are predisposed towards it, and there are environmental triggers. Of all of the common disorders, autism is actually the most genetic, meaning that if you look at how much is genetic and how much is environmental, there's more of a genetic component than any of the other common disorders. But that doesn't mean that environment's not important at all, because genetics it's the hand that you were dealt in life. But how you play your hand is your environment. And you can play a bad hand really well or a good hand really poorly. And environment is really important. Environment is the trigger that triggers off disease, while your likelihood of getting it is the genetics. And I'm a geneticist, so I tell people what the genetic potential is, and then I help you to treat your child or yourself based upon the genetic potential. But that doesn't mean that environment's not also important. And there's other doctors that are out there looking at the environment, including the microbiome, which is a major part of our environment, and then saying how to treat that. So I would say that the best treatment is to know your genes and to treat them, and know your environment to treat that as well. I'm just not the environment guy.
Yeah, it's okay. It's a whole, you need the whole picture, but it's
Yes.
a very important place to start with the mito. And this is a question from Yulia, and she's asking, can oxalates cause mito dysfunction?
I don't really know how to answer that question. Sometimes it can cause kidney stones. I'm not aware of them causing mitochondrial dysfunction.
Okay, perfect. And why don't you give us maybe another one of your case studies, maybe a little bit different. You talked about creatine with your other case. What is another very, let's say, common issue that you've seen, a change in the DNA that you were able to treat and saw positives with that child or adult?
Well, let me give you a primary mitochondrial one. Here, let me go ahead and share. There's like 25 buttons I have to push to share the screen, so it takes a while. Okay, so here's Carter. Carter after the MMR vaccination, and make sure that we talk about that before we go. And he stopped speaking. He was later diagnosed with autism. And biochemical laboratory testing suggests the possibility of a mitochondrial disorder. It shows mitochondrial dysfunction. Like I said, 80% or so do that. And then DNA sequencing found a TRAP1 variant. Now, this variant is seen in 1% of people. I kid you not, 1%. So this is not the cause of his autism. This is a contributing factor. So this is what the TRAP1 looks like as a chaperone in the mitochondria. So what it does is it grabs proteins at times of high oxidative stress and uses like a claw. You see at the top right there, the claw is closed, but that upper part can open up and to form like a claw. And it grabs proteins. It uses ATP to do that, to make the energy. The ATP is in the green in that little figure. And it tightly binds proteins in the mitochondria at times of oxidative stress so they don't unwind, which is denatured or cooking. And so the mutation is at the ATP binding site in Carter and in a lot of people. And this is this particular mutation, people have this that often have like irritable bowel and migraine and chronic fatigue, because people with it tend to have a lot of functional problems. But I saw a whole bunch of people with this mutation with autism. With collaborators at Georgia Tech, they looked at this in the computer in 3 dimensions and say, okay, how does the protein look in the mutant protein and in the wild type or normal protein, and what's the difference? And then let's put drugs in the binding site for ATP, and then let's see which one will block that binding site. Because what I'm thinking is that the binding site causes an ATP eating machine in the mutant molecule, and I want to block the binding site in the mutant molecule, but not in the normal molecule, to stop the ATP eating. And so they came up with what was it? It was SAMI, which is something that a lot of people do over the counter. So we gave them SAMI, and things got worse. They go, okay, well, SAMI works, but it goes in the wrong direction. So the next thing we tried from the computer was Kytril, which is a drug that's used in nausea and vomiting. And Kytril made a huge difference in these patients. So we said, okay, let's try it in Carter, because Carter has autism and he has 253. And when we gave it to Carter, he got a lot better. And he had been off of Kytril 5 times that I'm aware of. There's been nationwide shortages of the drug. And every time he goes off of it, he reverses. And every time he goes back on it, he gets better. So this is showing you a primary mitochondrial disorder. This is somebody who did do much better on mitochondrial cocktail, but he still had autism. And when you give him Kytril, he basically has ADHD. He's in regular classes, and he's doing very well on ADHD medications. And he's pretty much a normal boy at this point, when before he had really quite severe autism. So this gives you an idea of, and it's very difficult to make this connection, because how many sequence variants does the average patient have that are present in at least 1% of the DNA? It's about 1,000 or so. So the average person has 1,000 sequence variants that are in 1% or less of people. So it's, you really have to, like I said, you have to dive down really deep into the list and to look for things that might be related. But that gives you an idea. Another one, I don't know if I have one here or not, a lot of channelopathies, calcium channelopathies. Whoops, that looks interesting. There's a lot of calcium channelopathies, and sometimes I get other channelopathies, particularly in the patients that have a lot of chronic pain, is that they have an ion channel in their nerve cell which is leaking and letting too much calcium or too much sodium in, or too much potassium. So that's another thing. And those are treated by blocking the channel with a particular drug, and I need to know exactly which channel it is. Are you still there?
Oh, I'm still here.
Okay, okay, all right.
Everyone's saying how amazing this information is, because it's such an amazing approach to be able to say, as opposed to guessing and throwing darts, in the dark and trying to just, and to be able to, like you're saying, it's very, individualized medicine for each individual case. And it's so important, and it makes a huge difference when there's someone looking at the whole picture, who can really say, hey, this is what's going on. And it's interesting that so many of these cases have this, like on your last in Carter, talking about this chitril and how it's also for nausea and vomiting. It's a very interesting like interconnection with a lot of these. I just wonder, now I have to dive more into that later and see why. Why is it that these are all interconnected, you know?
Well, these genes are not autism genes. They're genes that make a protein, and the protein does something. And while some of them, like SHANK2, really only operate in the brain, most of them are proteins that are in cells all throughout the body. So you do have other things. And people have noticed for a long time that most kids with autism or adults with autism, they just don't have autism. They have other issues in the neurological system and other systems as well. And that's why it really, really helps to get to know the patient backwards and forwards, is to understand, you know, which genes it is likely to be. And most importantly, when I get my gene list together and say, okay, here's the 10 things that I found, let's talk about them, to figure, you know, to zero on the one or two that's most important. Because I mean, these genes do other things, and these other things may or may not be present. Like, you know, said that I have tend to look at the functional disease issues because that's where I came from in the functional side, but there are many, many other ones as well.
No, absolutely.
The future is an amazing place, isn't it?
It is. I mean, well, that's what we're all counting on, is for you guys to keep hacking away and, you know, giving our kids answers. And there's so many people. It's not just autism, but obviously that's our main focus here. But there's so many people with so many problems and so many chronic diseases. And if you can just get someone who is passionate enough to look under the hood to be able to tell you, hey, this is what's going on. Let's approach it this way. Yeah, no one's done this yet. That's a wonderful thing. So everyone's loving what you're saying. And so there's a couple of questions that have come up about channelopathy. Maybe you want to dive into that a little bit, because it seems like people don't really know. Like, there's a couple of questions like how channelopathy is diagnosed, what kind of testing. So maybe you want to just touch on that a little bit.
Channelopathy is probably the most common condition that most people have never heard of, and there's no channelopathy experts anywhere. I've been trying to learn more and more about the channels, and they're very complex. The channels are what they do is they allow ions, salts, basically, sodium, potassium, chloride, calcium, magnesium, to get from one side of a membrane to the other side of a membrane. That could be the cell membrane, it could be the membrane of the nucleus or the endoplasmic reticulum or something else. So these ions are pumped using energy, ATP, on one side of the membrane. And then when the ion channel opens up, they just go across, from the side that they're the highest concentration to the side that they're the lowest concentration. So usually there's these little pulses in which a channel opens up, but say the calcium goes through, it closes again. Since calcium has an electric charge, it changes the electric properties of the membrane, and things happen. And that is usually how cells do something. How does a muscle cell contract? How does a gland cell secrete? How does a nerve cell send an impulse? They do that by opening ion channels and changing the electrical properties of the membrane, and that's the signal for the cell to do its thing. And if the ion channels are leaking, then the cell's going to be hyperactive, and it's going to do too much of it. Sometimes it's an ion channel that's not working, particularly if it's like a GABA channel, a chloride channel, that's an inhibitory channel. If you don't have enough inhibitory channel, then the cell is hyperactive. So you get things that are caused by a hyperactive nervous system. So the most common things would be pain, fatigue, nausea. But you can imagine that a hyperactive nervous system in the brain can cause epilepsy, migraine, autism, anxiety, ADHD. Mental confusion. People, they're saying like their brain is just going off on its own and racing. So the patients that are intelligent, that are older, can give many different descriptions of what's going on. And it's basically that their nerves are just having a good old time firing. I tell the little kids that their nerves are lying, that they're sending false impulses because the cell is going off when it's not supposed to.
Things. Okay, thank you for explaining that. Carla has a question which says, which methodology is Avantix used for its sequencing? I'm not sure. I guess that would be another. I'm not sure what Avantix is. And she said we find
Variantix?
Yeah, in Avantix, and she said we have many different. Excuse me. We find many differences in findings from lab to lab. So, what are your what are your preferred labs, I guess, that you work with? And because yeah, go ahead.
Okay. For neurodevelopmental disorders, it's extremely important to do a trio, to do both parents and the patient, because then we can look for de novos. It's really extremely difficult to look for de novos if you don't have the sequence of all three of them up front. So, and I like to do whole genome sequencing. Exome is to do all 23,000 genes. Genome is the exome plus everything between the genes. And that's 98% of the DNA is between the genes. So genome is a lot more sequencing. It's more money, obviously. But in genome, you get the genetic architecture. So you can tell if pieces are missing or extra. So you get a microarray plus an exome sequence. Plus, you will know if there's sequence variants that cause disease outside of the exome. For instance, like the pharmacogenomic mutations. Do you use an SSRI like Zoloft, or do you use an SNRI like Cymbalta? Which one's more likely to work? Do you use a smaller dose because the patient can't break it down, and even a normal dose will cause a lot of side effects? Or do you have to use a very high dose because the liver breaks it down like crazy, and a normal dose isn't going to do anything at all? I have a lot of patients that the right drug was tried and had side effects because they were a poor metabolizer. Later, we just tried 1/4 of the dose and it worked great. Other patients, the right dose was tried and it didn't work because they're a rapid metabolizer. These mutations are outside the exome. They're generally in the genome. There's some mitochondrial DNA, which is really important. I didn't show you that, but there's a lot of patients with mitochondrial DNA mutations, and that causes mitochondrial dysfunction and a treatable type of autism and other disease. Often you get other issues as well, such as functional disease. And you get that when you get the whole genome, but you rarely get that when you get the exome. And also you can look at the trinucleotide repeats, like Fragile X, and there's about 40 others that cause disease. So if you do genome in the right laboratory, you get all of that and more from one test. So it's cheaper than ordering all the tests separately. I use Variantix. It's spelled like variant, like a variant in the DNA with a YX at the end. And it's in the Boston area. I use that lab because, well, they're good and they have great, I like the people there. They have good, they work very well with the families. They have reasonable price for extremely good sequencing, so it's very unlikely to have artifacts that are not real. But unfortunately, a lot of labs have a lot of things that are not real that are found. But the main reason I use them is that they let me on the computer program, and I can look at the entire sequence myself, and that makes a big difference, particularly to make sure to look at the variant that I'm looking at and it says, is this really real? Can we really say that this is in the patient for absolute positive and not just that we think that it's real? And also all the computer tools that they allow me to use on there just makes things go faster, and that means I can do a much better dive into everybody. So that's what I recommend. If you're under 21 and you have autism and you have a PPO, it's very likely that the insurance will pay for it. HMOs is sort of hit and miss, but they're doing much better. Medicaid and Medicare, it's very state by state. It used to be 0, and now more than half the states are doing that now. Over age 21, it's much more difficult, but we have gotten sequencing. That's the gold standard, but there are patients in which we haven't been able to do the gold standard because it's too expensive, and we have done less sequencing. But in particular, like a GeneDx sequence that then goes through GeneSavvy, and I look at the Excel data folder. As you can see in that one patient that gave me the diagnosis. That's another way to go.
Okay, perfect. And then I know you wanted to circle back to this, so let's go to that. You were talking about vaccination, and you were talking about
that's right.
in the MMR. So let's jump into that pool.
Yeah, I know. That's like a cesspool to jump into. I mean, there's no way out of that without getting tainted either way. I have 4 of my own children, and they're completely vaccinated. The vast majority of my patients, but not all of them are fully vaccinated. I believe in vaccinations. I believe that they made a big difference. On the other hand, I am one of the people that have been an expert witness in the Washington, D.C. It's actually 2 blocks from the White House at the vaccine court. And I have argued in vaccine court in several cases that the vaccine was the significant cause of the disease in that child. I recognize that while vaccines are overall good, that there are some kids that do get epilepsy, mental retardation, autism, et cetera, from that. And being based in Los Angeles, where a lot of my patients have gotten pertussis and measles and been in the ICU, unfortunately no one's died yet, but it's come close a few times, I realize that there's no safe way to vaccinate and not vaccinate have risks, and I try to reduce the risk as much as possible in my patients. All of the cases I've ever seen with vaccine-related injury were kids that were under the age of 2. They're between 4 years and 2 months, and almost all of them have been 6 to 18 months. There's extremely few outside that. So I say it's really uncommon after age 2. Oh, by the way, between 6 and 18 months, that's when the brain is using the most energy. The mitochondria are moving the fastest. The brain is growing the fastest. It's adding the most protein to it. It's the time of the highest brain energy use. It's a time of high vulnerability to everything, near drownings, infections, everything that you can think of. I've never seen it after age 2, so I say, okay, age 3. Let's just do age 3. We'll be safe. And a lot of the families they're skittish, and they say, okay, kindergarten, age 5. So it's not pro-vax, it's not anti-vax. I like to call it smart vax. You get the vaccines slower. You don't go into the waiting room. Most of the patients that have had vaccine-related injury have had they got a viral illness, because when they were in the hospital seizing, somebody said that they had a white count that was high, and that they had that you can see with the virus, like a lymphocytes are low, and that you can see they had a runny nose and they were stuffed up and everything. They probably got a virus in the pediatrician's waiting room, and that increases the chance of disease as well. And they often got Tylenol, which is mitotoxic. So it's sort of the perfect storm. They had a genetic predisposition. That's why I'm at the vaccine court talking about it. They had a gene that predisposed to have vaccine-related injury. They had the vaccines, a lot of vaccines. They had a viral illness. They had Tylenol, and they were at the perfect age. And so all of that together contributed to a vaccine-related injury. So what I do is I say, we can't get rid of the underlying genetics. We certainly can get rid of the age problem. We can get rid of the Tylenol problem. Ibuprofen is okay. We can bring them in the back door and not have them touch anything, get vaccinated on a Friday afternoon, and spend a nice evening and weekend at home so they don't get a viral infection. And if anything does happen, we can jump on it immediately, put them on IVs in the hospital, and deal with it. I've been doing this for 30 years, and nobody's ever had any issues. A lot of the patients had vaccine problems beforehand, but not after. So I'm aware that vaccines are a risk factor for autism. Viral infections and bacterial infections you get in the community, they're also a risk at that age. But I'm also, well, anyway, I'm a moderate, so both sides will call me the enemy.
That's no, I think it's important to say your stance on it. And as well, just to clarify, when you were talking, I know you also talk about how you do run it is you also run them slower. Like, let's do 1, let's do 2, let's do as we see fit, but not 17 in one setting at 4 months. And then, like you said, viral infections going crazy. So I think it's good to clarify where you stand on that, and I appreciate that. Now, one person had also asked, I know you had kind of touched on it, but with your specific case of Carter, who regressed with the situations going on in his life, also after the MMR, you had mentioned obviously that wasn't. Obviously, it's always going to be environment, predisposition.
Mm-hmm.
But can you share a little bit of his case on how he regressed on the MMR? Or after, excuse me.
I don't remember exactly how it was. I think that at that point he stopped talking, and so he had autistic regression. I believe that's what it is. And if it's not, that's the most common. That they stop talking at that age. They stop looking at their mother, and they stop interacting as much. And They cry when you interact with instead of cooing. That's the usual thing that happens. And the MMR is not the only one by any means. I've seen it with other vaccines, but the MMR is probably more than half the cases. So you say, one at a time. I don't recommend doing the D, the P, and the T separately. Then you're giving the kid like 40 different vaccinations. There's 40 different chances to get a viral infection in the pediatrician's waiting room, no matter how careful you are. But the NMR is probably a good idea to give separately. Give the MMR in one shot, but to give it separate from other vaccines. And this is just what I recommend. There's, based upon my understanding of the science, and there's no studies to suggest for or against any of this, unfortunately.
That's very accurate. Okay, and I wanted to also touch on, we're going to go back to carnitine for 1 second. This is from Kelly. She said, can you have high carnitine levels in the blood, but low levels in the muscle? If so, how would you treat that?
Well, if you have a mutation in the carnitine transporter, SLC22A5, and I always have to look for that on DNA, then you can have normal carnitine or even a little bit elevated in the blood and have a lot less in the cells. So yes, you can have that, and that's one of the genes I'm always looking for mutations in. But otherwise, it's going to be pretty similar. The carnitine transporter, if you have 2 mutations in it, then you lose carnitine in the urine like crazy. You have extremely low carnitine, and you present very, very early in life. And that I've seen in many cases. But the ones with autism tend to be ones in which they have 1 mutation in the carnitine transporter, so that their carnitines are a little low in the blood and they're lower in the cells. And you just give them high doses of carnitine, and that corrects that.
Okay. Perfect. There was one question that had come up earlier, and I just wanted to find it. And it was regarding heavy metals. What is your approach to heavy metals? Do you find this to be a factor at all, with your cases specifically?
I'm the genetics guy. I realize that heavy metals are a trigger for disease, and that a lot of the patients are tested for heavy metals, and that could be a contributing factor in the environment. So I'm not against it or whatever. I haven't seen a lot of patients with heavy metal problems. I think that in our society, it's probably a good idea to look for that, but I haven't seen that as a significant factor in a lot of patients.
Perfect.
And then, I'm not the one that does that.
Yeah. Okay, this is a question from Pierrette. She says, can you get anywhere, obviously this is for you specifically, can you get anywhere with just sequencing from the child? Or do you really want to have, to see if it's genetic or if it's not? Do you want to have all 3, or can you get anywhere just from the child's whole genome?
Well, I mean, we can do a lot in the child, but we can do a lot more if we have the parental sequences. Sometimes one of the parents is simply not available. And in that case, we just have to deal with what we have. It makes it much more difficult. If it's one of the situations that looks like a de novo case, somebody with significant neurodevelopmental problems and essentially negative family history, then it really needs the trio, and you're probably going to miss it. But sometimes we can find a variant that is really, really obvious that this is probably it. And you can chase it in the family members if you have them. It's just difficult without the parents.
Absolutely wonderful. Okay, we've taken a lot of your time today. I just wanted to maybe wrap it up. And is there anything you'd like to share with the audience, kind of like as a last, advice, and just to give everybody maybe some hope and everything, and how they can? I'm going to give all the information on how to contact you. But do you have any advice for our listeners?
Well, I mean, nutrition. Nutrition is so important that I went ahead and started a company to provide those products. But I mean, if you use those products or from a competitor, or if you just a la carte from the pharmacy, really nutrition is extremely important. It's not just that kids with autism have poor diets, most of them do, but it's that you need to support the mitochondria with really huge doses of certain vitamins and minerals. And not just to use one at a time, but to use a whole lot of them at the same time, because think about it as the mitochondria is an assembly line, and it really is. I have another slide somewhere, it'll take too long to find it, to show an electron micrograph that shows it really is an assembly line that the electrons build energy on. And if you take a guy in the middle of the assembly line, let's say that's a bunch of people putting together an automobile, if you give the center guy vitamins, and he makes his cars much faster. You're not making more cars, you're just causing chaos. The whole line needs to be faster. I think a lot of the side effects people get when they try a multivitamin is that they're just adding power to one aspect of the mitochondria, not the rest. I really am a firm believer that nutrition is important and that you should use cocktails that have a large number of components together. That and get tested for DNA. Find out what your cards are. Your cards are what they are. People don't want to know because they figure it's going to be, they'll find something in the DNA. It means that they can't do anything about that. That's not true. When you know the cards in your hand, you can play the cards better.
I think it's great advice. Nutrition, and let's call you to get a nice full sequence under the hood. So wonderful. Thank you so much for spending time with us. Just to give a reminder, so you can find Dr. Boles at neuroneeds.com has his Mito supplements, has a ton of information, and also at neuroabilities.com/neurogenomics. And also consider donating to the Brain Foundation. If you'd like to give a donation, it goes to more research and more funding for everyone. And just like Dr. Boles, to continue with our amazing fight for our kids and adults with autism. So thank you so much for spending time with us and sharing your slides. I probably want to see all of them next time. So thank you so much.
You're welcome.
Have a wonderful weekend.
You too.
Thank you. Bye-bye.